Welcome to You May Not Get Paid. This is Steve Anderson. We're excited for our webinar today. Record attendance and a lot of interest in the annual changes that happen to the CDT codes. And so this will be a very rapid fire presentation. As mentioned previously, it is being recorded. So you're welcome to go back to crowncouncil.org under the section under webinars, and you'll be able to review the information here today. So what we've put together is we've tried to simplify the changes that have taken place so that you can know the usable ones and the ones that are the most important that will affect what you do in the office on a daily basis. So our presenter today is Mary Beth Brown, one of our practice advisors at the Total Patient Service Institute. Mary Beth has been in the dental industry from the time she was a child. She was raised by a very experienced dentist and has spent her entire career in dentistry. As a practice advisor, Mary Beth is in and out of dental practices almost every day across the country, helping with case acceptance, management issues, as well as coding issues, which is our topic today. And she is our go-to expert at the Total Patient Service Institute for coding and maximizing your reimbursement. So we're excited for the presentation today. And with that, I will turn the time over to Mary Beth Brown.
Good morning, everybody, and thank you once again for joining us for 2014's code changes. It's that time again to review and return to the new Code Maintenance Committee's changes. There are 84 changes that became effective January 1st of 2013, and this year we'll have only 29 code changes. 3 new categories and 4 existing codes will be deleted. So moving forward, Steve has always talked to us about the Pareto Principle, also known as the 80-20 rule. And so in keeping in spirit with the vital few, our topic discussion today will center around what we felt were the top 6 that will help us the most effectively help our patients and our practices. So with that, we're going to start with the caries risk assessment documentation. There are 3 subcategories, as you see on the screen: D0601, which is the findings of low risk, D0602, the finding of moderate, and D0603 with the findings of high risk. Now, the CMC believes that the caries risk assessments is going to be a great distinction and separate how our patients' health status is. And this in no way will prevent them from ever having any care, but it will help us better categorize them in the types of care that they will need. So it'll be very important that starting the exam process that we assess which category, whether it's 0601, 0602, or 603, our patients will be falling under. Moving forward, the CMC has felt that it was appropriate to give us an unspecified preventative procedures report code, the D1999. Now, many of us have already been using the xylitol products or the MI paste or the Sonocares or any type of oral product for cleansing in the practices, and have pretty much created your own subcategory code. Because these do not bill out with insurance, they're just an internal code, you may feel more comfortable leaving the code in place that you currently have. I wanted to make sure that you were aware that they have created this code. It was the only category that had not had the unspecified procedure code attached to it in the past. I think one of the most interesting one that has come in is the 2921, a reattachment of a tooth fragment for a child or an adult. It's an incisal edge or a cusp. Often the remnants can be reattached until the tooth is fully developed and another procedure can be done for that child or that young adult, or we wait until the tooth is exfoliated and the new permanent tooth has come in. So this procedure code has given maybe the pediatric specialists or the general specialists that have children within their practice a code that will work well for the reattachment. Now, this is the most interesting one that they, I think, released in 2014, the 2949. It's the non-buildup, if you might. It's a restorative foundation for an indirect restoration. What that means when you read through the information that they've provided us is that often there are small blemishes or shapes that need to be addressed once the decay or the filling has been removed, and it's less than 60% of the tooth that's missing. The CMC has asked that we use the 2949 in the presence rather than the 2950 for that buildup that we've done in the past. So now we have two choices to utilize in the reporting of the buildup and the non-buildup underneath our fixed restorations. For those that are doing endodontic procedures in your practice, sometimes we find that the patient has lost a lot of bone due to the infection at the tip of the root, or we call it the apex. And in the past, when we've billed a bone graft or a tissue graft in the area of endodontic treatment, in the absence of periodontal treatment, they were denied by the insurance company. And so the patients lost financially. They gained because we were able to give them great health, but they lost because they didn't get the remittance. So what we found is that the CMC created these 4 codes, all in conjunction with bone grafting and regeneration of either tissue or biological material at the conclusion of a root canal, and in conjunction with a root canal rather than in a periodontal procedure. And this should better help the patients get remittance and the practice get remittance for a great procedure that's being done currently in the hands of both specialists and general offices. All right, now this one's probably not a great surprise, but you know, hygienists have been irrigating during their root planing and scaling or their periodontal modular therapy appointments for quite a while. There's never been a code for us to be able to build this out. So gingival irrigation is new this year for us, the 4921 code. This is done and billed by the quadrant so that the hygienist and the patient can better benefit from the procedure that is a therapeutic, administrative of bacterial rinsing during the process and removal of the other bioburden in the process of that root count or the root planing and scaling appointments. Along in that same hygiene category, we have the 5994. It's called a periodontal medicament carrier. Some of us have heard of it in the past called Perio Select. It's a custom-made mouthpiece, if you might, that is laboratory formed, and it has to be formed in a third-party laboratory and go into the specifications of the Perio Select design in order for us to build that out. So if we're using the STAR vacuum former or the vacuum former in our office, we may not use the 5994 code for that. Now, the next codes that has become very popular in our practice to use are the overdentures and overpartials for patients that are, you know, have lost their teeth and yet we're utilizing the implant system. And in the past, the 5861 did not specify the arch. So what you'll notice for the partial is that they've changed it to the 5864 for the maxillary and the 5866 for the mandibular. So it'll be very important that you use the correct code for the correct arch. And then the proponent for the full denture, overdenture, and overpartial, which in the past was the 5860, is now the 5863 and the 5865. So many of our patients are really seeking this type of care, so it's great that we've been able to be more specific in the procedures that we're actually able to help them with. Implant seems to be another a big area of growth, and there are several, as you know. We've got the standard implants, the wide-bodied implants, what we just talked about, and then the use of the mini implant, the 6013. And there's never been a code really to distinguish with the mini implant in the past, and it of course is different than the 6010 in design and how it is also feed out and reimbursed. So this will be a new code for us to be able to use. Last but not least, in the area of orthodontics, they have finally come up with an 8694, the repair of the fixed retainer. So we all know that as the lingual bar. And, you know, we've never had a code for that in the past, and many questions have been asked as to what do I bill out or what do I use to reattach a lingual bar? Well, they've given us a code now. It's an 8694, so problem solved. That was about it for the 6 most important updates we felt we wanted to share with you this year. Now I'd like to go back, if it's okay with you, and ask how often are you using these codes? This is last year's 2013 changes. The creation of the 0145, which is the exam code for the child that's 3 years or under. That comes to your practice for that first happy visit. And then the new code, the D0180, for most patients that have either health concerns or periodontal disease, the 0180 was added in place of the exam for the healthy person, which is the 0150. There's a great price difference for the practice, up to $30 per exam. And the benefit is it really helps you categorize your patients into the risk assessment that you need for spending more time with them when they have a health concern versus someone that's in tip-top shape. Now, Dr. Charles Blair brought to us last year that the D9110 was a great opportunity for patients that came in with an emergency situation. And several of the reasons he pointed out last year was that it was allowed 2 to 3 times a year. It wasn't a take-back code, if you remember what he said. So if you were to do a filling and then turn around into a crown on someone within a 6-month or 1 year period of time, that was a take-back. They would reduce the cost of the crown, the amount of the filling, because of that short period of time. And your palliative code is not a take-back code. Now remember, you can't report any other treatment on that same day. So if it's exam and x-ray, then it's just a prescription, it's a perfect time to utilize that code. Our periodontal ongoing maintenance appointments, the 4910, you know, it's really important, and often we've been told that patients can fluctuate between the 1110 and the 4910 in those 4 appointments during the year. And what we've learned is that once you take a patient off the 4910 and put them in a cycle of a 1110, before you can ever go back to coding out the 4910 again, you have to go through root planning and scaling process with that patient. So you're not really benefiting the patient or the practice if you alternate between visits, because unless that patient goes through the extensive root planning and scaling and modular therapy, they would be omitted from any further payments in that category through their compensation program. Remember that your periodic oral evaluation, the 120, is not a part of that 4910. And if that patient's had a change in their health status and they've been healthy and we've changed them to the 4910, remember to use the D010180 code, the Comprehensive Periodontal Oral Evaluation. Sometimes it will be reimbursed at the 120 rate, and that's okay. It's the opportunity for us to be able to make sure that the patients are being billed out properly. It's important when you use the 4910 that you attach a narrative for each of your patients. And that's going to be in section number 35 on your claim form. You will say remarks or reasons. And if you will share with them that the 4910 is not being reimbursed, that please pay the alternate benefit of the 1110. But we don't recode it that way. Periodontal maintenance will stay at the 4910 and is exclusive or inclusive of the prophylaxis fee of the 1110. So I hope that this narrative will give you the information and the ammunition to help get payment for your patients without feeling the need to change that code. One of the opportunities that we have been exposed to in the past is your hard tissue crown lengthening procedure, the 4249 code. Anytime that the crown is too close to the bone and the doctor has to reshape that for a good fitting crown, it is a wonderful opportunity to use that code. Also, there are times that the soft tissue needs to be removed and so that the crown fits comfortably or that the impression can be taken without any problems. And that code is the D4211 code. And it's very important that we utilize this in a way to better maintain the patient's health as well as to get reimbursement for the procedure that the doctors are doing, or the giveaway codes. And then, of course, there's the gingivectomy as well. Last but not least, in some of the big code changes from last year was, remember, we went to the 1206 fluoride varnish, and that was for both children and or adults. And then with the 1208, which is the fluoride application, the non-varnish, the 1-minute foam, if you might, or the fluoride rinses that we often use in the practices as well. And that was for both children and adults. Remember that there is no caries risk, is no longer a consideration for the 1206. It is as needed per patient, and you don't have to deem that they have a reason to have a fluoride treatment. Remember, the 1203 and the 1204 were deleted, so look and make sure that you've idolized those in your codes, taken them out of all of your quick and hot buttons and hid them deep into the old systems. Now, you'll probably notice the gentleman in the orange jumpsuit, leisure suit, if you might, with the handcuffs. Well, I don't know how many people look great in orange in that type of accessory, but we want to talk about the oops, be careful whens. That we want to call it the stay out of jail, if you might. And this is a big, big thing that we learned last year, and some of us have known for a long time, and that is that it is never okay to submit a full fee for a procedure to your insurance company, whether you're in network or out of network, and then receive their percentage of coverage for the procedure, and then write off the patient's balance or zeroing out the account. The insurance companies consider that fraud, and they frown upon that. They don't look highly upon that. So if there's ever an audit in your office for whatever reason, please be aware that that is not a procedure. So doctors, at the end of the day, when you're checking your accounts adjustments, make sure that you're checking to make sure that this procedure's not been being zeroed out. You might have to have an office meeting about what you're going to do differently. remember that if you do choose to have a agreement with a patient where you're going to zero out that account balance, that prior to submitting the claim in box number 35 on your insurance code form, that you allow the insurance company the same information that you're giving the patient, which is just a quick note that says, we're going to be reducing the cost of this procedure $80 to Mr. Joe Smith, so that the insurance company has the opportunity to make the decision as to whether they're going to reduce their portion of payment by $80 as well. One of the big red flags that we're hearing and seeing a lot of is the surgical extractions. The 7210 have been being used in situations where it's really not a surgical extraction. You know, it pays about 60 to 90% more than the 7140. And so often if it's a little more complicated extraction, that code's been being used. Remember that it does require the removal of bone and or sectioning a tooth. If you're doing any of those types of procedures, then you may freely code the 7210. I also might think of taking an intraoral photo of that sectioned tooth just in case. Now our crown buildup, the 2950, you know, has been used often for the endodontic follow post procedure. And remember that we learned this last year that we're to use the single surface filling or the double surface filling code. So to make sure that the coding is done properly, we wouldn't use the buildup, the 2950, for that type of a procedure. And we're finding that if you've done a root canal on someone and you need to do a post and prefab core, that your reimbursement for your procedure is far greater for a tooth that's had endodontic procedure. So use that 2954 code if you'd like, or the indirect cast or milled post, the 2952. So a couple of the details that we learned last time about a core buildup, the 2950, is that it was a must for retention of a crown, strengthening of a tooth. But we remember we're not going to be using it for the code now. We're going to use the 2949 instead, if it's only to change the box form or take away the undercuts or make that ideal prep. So the 2950 is if 65% of or more of the tooth was missing and or the tooth was endodontically treated and we wanted to use it with the core and the buildup. Make sure to submit an x-ray with that as well, post and pre. Thank you all for being such great listeners this morning. And that's going to end it as far as the updates that we have. So now we're going to go ahead and take questions. So how often, the first question is going to be from, okay, how often do we need to do the assessment, and should it be done in the hygiene appointment or with the doctor? And that's for the caries assessment. That's a really great question. Every time that you're doing an exam with a patient, in whether it's a new patient, so if you're using the 0150 or the 10180 or the 0120, you're welcome to use the caries assessment for that patient. You know, as with any new coding, the details of what the ADA will request or the insurance companies will request will pan out after 6 months to a year. The next question is the D2950 is for more than 60% of the tooth structure. Yes, that's correct. So we'll be using the non-buildup code that we talked about earlier when There's less when there's more than 60% of the tooth present. Okay. All right. Define palliative more. Do you have to touch the patient to be able to use that? That's a really great question. So palliative treatment is definitely when you've gone in and you've done a visual of what's going on with the patient, whether you've assessed that they have an abscess and then need to be referred out to the endodontist or the oral surgeon, or the patients come in and they've got a toothache and you're welcome to take an x-ray at that point in time to define what's going on. If you find that the tooth is hitting high and you've done an occlusal an adjustment to the occlusion, you're welcome to use the palliative treatment there to take away the percussion of the patient. So yes, you can touch the patient. Sometimes you don't have to. So the palliative treatment is a non-defined, great code to be used in multiple ways. Now, if I were going to be applying a desensitizer to a patient's tooth because they were cold sensitive, then I would utilize my desensitizing, I would use my exam code, and then I'd use my desensitizing code versus my palliative treatment. Oh, excuse me, I was reading the question silently. I need to read it aloud. What do you mean when charting when using the periodontal code? So when you're using the periodontal codes, you need to make sure that you're charting your soft tissue. And that means you need your bleeding points, your pocket measurements, your recession, as well as any mobility. So those are typically the 5 areas that we cover when utilizing charting with periodontal codes. All right, do we need to use the narrative for the 4910 if we're already getting paid for that code? Well, that is a great question. If you're already getting paid for the 4910 and you have a relationship with that patient and that insurance company, then my saying is, if all is good, leave it that way. If it's a new patient that you're just starting periodontal procedures for and it's the first 4910, I would go ahead and use the narrative to go along with that. Well, good morning to you as well. How will we bill insurance when we have patients, when we have given a patient a discount? So typically, that's a great question. If you've given a patient a 20% discount, then the fee that you would submit to insurance would be reduced by that 20%. So it's just inclusive in the fee that you submit. Next question. Is it a problem if you apply varnish and charge the 1208 code? You know, the 1208 code is for topical varnish everywhere in the mouth. And so I think the question that you're maybe asking is if I'm using the desensitizing varnish in a specific area. So you are comfortable in doing both because they address different situations. So if you've got a root surface area that you're specifically putting the fluoride light cured varnish on, then feel free, and you're doing a full fluoride treatment as well, feel free to use both at the same time. Okay, the next question is there a D0181, a doctor-only code, considering that it replaces the D120? No, you know, as far as I know, there's a 180, but not a 181. Great question. I will keep my eyes and ears open for any changes like that and make sure to post it for you as soon as I see if there are. Next question, what is the significance of submitting the caries risk codes? You know, that is a real great question. Anytime the industry and the insurance industry and the American Dental Association come together and create a new pattern for reporting patient information, the reason behind that is so that they can have a better defined pattern of the patient care that's being delivered here in the United States, and I believe is their ultimate goal. There's not going to be a fee that's assessed to this at this point in time. It's just a better way to keep track of the types of patients that you're working with and making sure that you're keeping on track and passing that on with them. Next question was, is there a fee associated with the caries risk codes? At this point, there absolutely is not. The next question we've got is for write-offs. Sounds like there must be a dollar amount, not a percentage amount, or depending on what they would cover, yes? Otherwise, how would the insurance decide how to pay accordingly? That's really a great question. So we charge a specific fee for a tooth or a procedure that we do. And then the percentage that the insurance company is going to pay on is based on their fee table. So it does all come down to a dollar amount. If you're accepting 80% for a filling, let's say, and you're going to be writing off that 20%, and that 20% is maybe $50, then it would be best to share with the insurance company the portion or the percentage that you're writing off in a dollar figure. It just keeps it a lot easier. Our next questions, gosh, lots of great questions here today, guys. Are there any rules on the frequency for the D0180 exam code? Oh, great question. That code is very similar to using the 0150, which is at the beginning of a relationship with a patient, and or if it's a patient of record and you've seen them for their next appointment, and maybe it's a hygiene appointment and they're having their exam, and this patient has reported health changes, diabetes or heart attack, or they've started smoking, for goodness sakes, or something like that. That's a health change that you're able to utilize that D0180 code. They don't have to be absent for the practice from 2 to 3 years as if we were going to be doing a new 0150 code. They're not suggesting at this point in time to use it in placement of the 120 code, just at the beginning of a patient's relationship and or during a change in their health or status during and under your care. We have a nice long question here, and it has to do with the caries assessment. It says, using and recognize tool. This means that if you're using diagnostic caries indicator paste, and or does it also include traditional exposure and x-rays? Oh, Explorer for x-rays. Yes. So if you're using a Diagnodent and or an Explorer, that is one of the ways that you can assess your patient's care. I think the other thing that they're looking for there is a patient with low risk would be a patient that actually has no cavities or has no existing restorations in their mouth. Maybe somebody that's moderate is someone that's had dental disease in the past, but they haven't had any current or reactivity. And then someone that's in high level would be somebody that, has active caries in their mouth. Every time you see them, you've restored them, and the next time they come in, they have more cavities, and then the next time they come in, they have more cavities. So that would be a high-risk patient. The next question we have is on palliative treatment. When is it okay to charge without touching the patient? Examples. Oh, I'm supposed to give examples. So if you have, the patient has to come to the office, needless to say, and it would be best that they actually made it through the reception room door and sat in the chair. Um, and the doctor comes into the treatment room, and the doctor has to actually do the palliative treatment code as well. So he has to assess, or she has to assess the patient to make sure that there is, a problem that's going on. I hope that that's okay. Sometimes it's the patient's just got something they want you to look at on their tooth, and it doesn't require gloving up, so you wouldn't have to glove up in that instance. It's a great code to use, though. All right, the next question is on buildups. I knew this would be an exciting topic. Are you saying that buildups for onlays are not allowed? I use a buildup for ideal prep formation, and I noticed that several are not being covered. Well, I think that you're going to find that that is because the new non-buildup code that we talked about, the 2949, is going to be the best code for you to use in that situation. It is the restorative foundation, or making that ideal tooth structure for draw, or for making sure that the indirect procedure fits comfortably, just like you had designed. So don't use the 150 anymore, or the 2950 anymore. Go to the 2949, and let's see how that works for you. Another great question. A patient requires a 4341 and comes in for a maintenance in 2 to 3 months. Do we now, for the remaining time, only charge the 4910 and never a D1110? That is correct. That's exactly how we want to do it. So I don't know if you guys can see these questions or not, but I'm going to read this one again. So the patient's had a 4341 and has come back in 2 to 3 months for that maintenance appointment. And the question was, now for the remaining part of our charting and charging, would we do a 4910? That is correct. They never go back to a healthy person once they've had disease. It's kind of like being a diabetic. Once you're a diabetic, you're always a diabetic. They haven't, at least in this part of our life, they've not come up with a change for that. We have another great question. Do all the insurance companies pay the risk carries assessment? I want to reiterate, it is a new category, but it is a non-charged category at this point in time. So don't expect a payment, even though we've got a code. So don't assess anything to it. That's going to be paid for and reimbursed through the examination codes, whichever one of those 7 you choose to use. Oh, another great question. Also, when asking to downgrade and they refuse, saying must send as a D1110, out of luck, correct? I think I would rebut with that, and I would send them your root planing and scaling information and all of the clinical information, oral DNA screening if you happen to have it. The oral DNA screening would be phenomenal to be able to send in that report. And I would just say, this patient is a periodontal maintenance appointment, and I can't bill it out as a 1110. That would be insurance fraud. Next question is, what about the 4355? Can you use the narrative to let the insurance company know that the 110 is inclusive of this and will get an alternate benefit? The 4355 is a code that was designed for the patient that had so much calculus and crud on their teeth that you really couldn't do an exam. So the opportunity was to remove all the crud so you could do the exam. And if they have that much crud, they're probably going to go into root planing and scaling or some type of modular therapy rather than into a healthy mouth cleaning, would be my thought. So might want to reinvestigate how you're using that 4355 if you are. Another wonderful question. What happens when you have a family and a friend who will not be paying any portion? Is it illegal to accept insurance? that they have. Do you need to state that you are not charging the patient anything? Yes, that's correct. So family and friends that you're collecting only on insurance, remember in box number 35, you have to say, will not be collecting the patient's portion for this insurance. Another great question. Does insurance pay differently on fluoride varnish and fluoride applications? I'm not quite sure I understand the question. So there's a difference in the fee for the 1206 and the and I want to say 1204, and I know that's not the right code, but the fluoride rinse. So it's important. So yes, there is a difference in the fee that you can charge between the fluoride rinse and the fluoride varnish. How would you handle the write-offs for family members who aren't charged the difference after the insurance pays when filing? Again, I would just let the insurance companies know in advance that you're not going to be collecting anything from the patient in box number 35. And then there's another great question on billing insurance code 0180. Is the 180 only submitted under the doctor? That's correct. The doctors are doing the exam, so the billing of the exam should be under the provider that's doing the service. Just like if you had two doctors in the office working side by side, you would only bill out the procedures that they did. Cross billing is not a really great idea. Another great question. Do you know if the insurance companies noticed the narrative when submitting an electronic claim for a 4910 code? You know, I know that they're limited to characters, and I believe 35 characters is about as many as will show up in that box, but I cannot answer that because I've never been on the insurance side and I'm not able to see that. But I will ask that question and see if I can get an answer and post it on the website for everybody. Another great question. If treatment is done on a team member with dental insurance, are you saying it's not okay to write off their balance? Yes, it's not okay to write off the balance unless you tell the insurance company ahead of time that you're planning on writing off that balance. And that would be box number 35. All right, another great question. Can you use 2921 on an adult? It will apply to reattaching a piece of reattaching a piece of porcelain to a crown. You know, I don't believe we can, but I don't know that specifically. So may I get back with you on that personally? I'm not familiar enough with all of the coding on that since it's just been released, and I will verify before I answer if that's okay. Another great question, and this is on the bone grafting codes. Can you help define again when they'll pay in conjunction with surgery? So the bone grafting codes that we were talking about in utilization were for endodontic procedures, and in this instance. And so if the endodontic procedure has been performed and the abscess was large enough that you felt like that the apex needed to be opened and the abscess curetted out and then bone placed and then also a tissue covering, those would be the best times to use the codes we talked about in today's seminar. Insurance companies are used to cover fluoride treatment every 6 months, and now most seem to have gone to one per year. Is this for both fluoride varnish and typical tray application, or is this industry-wide? You know, that's a really great question. I kind of assess that to the same thing as when the airline industry looked at how they could save money by reducing to 1 olive on a salad, and they were wildly successful. And so the insurance company, of course, are always looking for ways to increase their bottom line. And I believe that the changes that they make are really more beneficial for the insurance company than for the insured patients. I don't have any specifics on that, just a feeling. Oh, great question. Do you have to do a caries risk assessment by law? No, you do not. Just to make you aware that that code is available out there, and you may be asked to submit that at some point in time with an insurance claim. So I wanted you to be aware that it's now available. A good question. Oh, it's a comment. I received a letter from Delta of Michigan, and they allowed $5 for the caries risk assessment. Fantastic. So even though we're not assessing a code for it or a fee for it, you've received $5. That is fantastic. Next question. How should we appeal a 180 when it is denied not to downgrade? When it's not downgraded? You know, that's a really great question. I think anytime a patient has inflammation and periodontal disease and they're being not compensated by the type of insurance that they've purchased, that we should do everything we can to give them that information. So if we can send the oral DNA screenings, we send all of the periodontal treatments. The doctor can write a risk assessment in how this is affecting the patient's health. And anything that we can do to help that patient receive that benefit, of course, is always the best thing to do. Next question, can you discuss how the health changes are communicated to the insurance company? Oh, when we're changing codes? I don't understand the question, Steve. Oh, when we change the, oh, okay, I got it. Thank you very much for that. So if the patient's had a health change, the best thing to do would be a narrative in section number 35, which says patient has had health changes, and then we would copy their dental health history and submit it along with the insurance billing. So attach it as a narrative. What percentage age or higher is the typical 1AO opposed to the 120? Oh, the 180 would be equivalent to the 150. So the 150 and the 180 vary about $20 to $30 depending upon your area and your zip code. And then your 150 over your 120s are significantly different. I think a periodic evaluation is in the $35 range, so it could be as much as $60 in that area. All right, here's one more question. What is the appropriate insurance form to use for submission? The latest ADA code format that we're utilizing, and I can get back to you on that, on each insurance, on each computer system, they've got them listed as the most current ADA form to use. And I can't answer that question, to be frankly honest. Would there, an intraoral of the prep before the buildup is placed, assist the insurance company in payment, and can you explain the 49.49? Yes. An intraoral photo of the prep before the buildup is always a phenomenal idea because it shows so much more than the two-dimensional X-ray that we have. And the 49.49 is a wonderful procedure that's used. So feel free to use that as you can. Can I elaborate on the 1999, the specifics for products that the patient takes home? Yes, you'll notice that it is not a fluoride varnish, or it's not a topical application or a RX medication, the pictures that we utilized earlier. The 1999 is a category that we talked about. I would call it the sundries of the practice, the retail of the practice. It might be the Sonicare toothbrush. It might be the gum floss threaders that we use. It could be the super floss that we dispense. Some offices dispense MI paste. Some offices dispense xylitol products. Some dispense water picks. So it would be what I would call the retail or resale part of the practice. Are you finding with insurance codes who typically won't cover buildups because they consider it a part of the crown procedure are covering the 2949? Well, now remember, the 2949 just came out about 14 days ago. So however they've given us the new codes to use, I think it's too early to tell what the pay rate's going to be. It'll take us a good 6 months to a year to find out what the return has been. Another great question, along with the write-offs, accepting assignment at 100%. Is it illegal to write off the deductible amount? Again, I think if you're choosing not to pay not to have the patient pay a portion of what their contract is with the insurance company, and then you have to inform the insurance company that you're not charging that patient. Next question, is there a limit to how much an employee gets to write off per year? No, there is no limit that I can know of. Now, the next question is, does the patient portion of the insurance need to be collected on the date of service so that you can make a payment arrangement for the patient portion? Well, that would be a really great way to do your financials so that you've got your patients either paying at the time of service or prepaying is something that we recommend. The next question we have is, what is the difference between the 9110 and the 140? They seem almost the same. The only changes, and there is no charge out for the D9110. You know, that's a really great question. So the 140 is the emergency exam, and the 9110 is actually the palliative treatment. So you could really charge them out together instead of simultaneously. Use them together. So one is the exam, and the palliative treatment is actually the doing of or the assessing of the situation. And then another question would be, what would a 40-11 be appropriate to use when using a laser or removing tissue around the tooth of an impressed? You know, you could act, it doesn't say how you need to remove the soft tissue, so the 40-11 could be used with the laser as well as a scalpel to remove that tissue, so that's an absolutely perfect time to use that for the gingival curettage. And or I guess you could use curettes as well. The last few years, insurance companies have been telling patients that out-of-network dentists are overcharging them. Ouch, that's rough. We know that this is not true, so what recourse do we have when this happens? You know, I think you have to have the relationship with the patient, and so when a patient comes in and has that type of a comment to you, that's probably not the real problem. It has to do with the quality of the relationship and the value that they perceive for the treatment that they've received. And I would go back to the relationship and then see if you couldn't address that with the patient. Another great question, do you still have to send an x-ray for the 2949? You know, I don't know that you'd want to send an x-ray because it should be minimal, but I sure would send an intraoral photo of showing, you know, the removed tooth structure or the areas that you were, you know, the voids that you're trying to fill so that you can get great coverage for that crown or that inlay or onlay. Another good question. Some insurance companies are now not allowing out-of-network dentists to get assignment of benefits. Delta Dental of Missouri and California, to be specific. Is there a way around this? Well, the only thing that I can tell you is if you don't want to join them, then which most people don't, then the better thing to do would just do prepayment to your patient, having the patient take care of the responsibilities to you, and then letting the checks go directly to the patient. That way you stay happy and the patient stays happy. Another great question: when do you bill out a crown or another multi-appointment procedure, at the start or at the seat? Does it matter if the insurance pays on the prep or the seat date? You know, that is a year-long question many people have asked, and I would say the majority of patient practices we work with, we suggest schedule or billing out the day we prepare. The insurance company may send you a request as to when the seat date was, if they pay at seat rather than at prep. And at that point, your crown is more than likely seated, so you can just put the seat date in at that point in time. But just to keep billing straight and make sure that the procedures are not lost and not billed out, we suggest billing out on the day you prepare the tooth. Another great question: when should I use the 2949 instead of the 2950? That's that buildup code question again. So the 2949 would be when you're making the tooth ideal for a crown preparation. Maybe it had a shallow filling or it has a natural defect. And when you've prepared the tooth, it's not going to allow your cast indirect procedure to fit comfortably. So then you would use the 2949. A 2950 would be used when the tooth is missing 60% of its remaining structure, and it's not just aesthetics, but it's really function to get that form, to get the crown to fit.
Very good. Thank you, Mary Beth, and thanks everybody for all of the questions. Those are great. Obviously, this is a hot topic with more, obviously, that we could cover, so I hope that gives you a good update on what's going on. As a final note, as you see on your screen, as a part of your Crown Council benefits, every practice is provided a free annual fee analysis that compares your fees to those in the area. We have that calendared for every practice, so that comes on an annual basis depending on where you are in the country. If in the event you're eager to get that immediately instead of waiting your turn, you're welcome to submit that request either by calling the Total Patient Service Institute or emailing us at answers@totalpatientservice.com. And in the email, just put fee analysis, and in the body, please send me my annual Crown Council fee analysis, and we'll get that run for you and back with a conversation with a member of our team that can help you identify that. Thanks again for your attendance today. Hope that the information has been useful. We'll most likely have a follow-up on this topic. Lots of great questions as the insurance world gets even more complicated. Thanks again for joining us, and stay tuned for the next Crown Council webinar coming up next month. We look forward to having you with us again. Have a great day.